All right, so it's my pleasure to introduce our next session. It's a panel discussion on the opioid epidemic and addiction treatment. We're pleased to have several researchers who are doing really interesting work in this area. So if the panelists can come up and please take seats. So Tony Miles, I'll start with you since you're here first. Tony Miles is a professor of epidemiology here at the UGA School of Public Health. She's a nationally known expert in geriatrics and gerontology, but she's coming out of the ivory tower and she's worked with Renee Unterman, some of you probably know, and working on the Georgia's Alzheimer's Dementia Task Force, also very active in addressing issues related to elder abuse in kind of institutional settings and community settings. And we have a connection because we're both, well, she's an alum of the Health and Aging Policy Fellows, and I'm a current fellow this year, and I would not be a fellow without her mentorship, so thank you for that. And a kind of interesting side note to that, when she was doing her fellowship year, she was working with Senator Max Baucus on the Finance Committee, and that was when the ACA was passed, right? So kind of circle of life, now we're coming back full circle, perhaps. And can the other panelists come up? I see Brian Caskey coming up, so I'll introduce him next. Brian Caskey is also a Health and Aging Policy Fellow. He's from University of Iowa and the School of Public Health, where he focuses on health policy and management. He's also done interesting studies on medical marijuana, which I'm sure he'll talk to us about. And currently, with his fellowship, he is working with Suzanne Collins, Senator Suzanne Collins on the Senate Help Staff. So he's there in the belly of the beast, right? Working on healthcare policy. And so if you want to get your input on how the new healthcare system would look like, talk to Brian. And incidentally, we're both from Chicago, but he's a fan of the team that did not win the World Series. Okay. All right. So between Brian and Tony, we have Dr. Macarena Garcia from the Centers for Disease Control. She's a senior health research scientist that's published some really useful and kind of groundbreaking research on opioids, which we'll be discussing today. Prior to joining this group, the CDC, she was in sub-Saharan Africa and Southeast Asia, working on HIV/AIDS issues. And we have Dr. Mark Fall, also from the Centers for Disease Control, doing a senior health scientist research, doing important research also on the opioid epidemic and also research related to violence prevention. So with that, I will stop talking because I want to hear from the panelists. And first, we will hear, well, while we're getting the PowerPoints ready, I'll start with Brian since Brian doesn't have a PowerPoint. So the first question is, you hear about the rural health, the opioid epidemic as being hitting rural areas particularly hard. Is that just perception or reality? Is it worse in rural areas?
Oh, I would say so, especially from my perspective as someone who studies the aging population, persons 65 and older, Medicare, Medicaid beneficiaries. They're disproportionately represented in rural communities. Iowa, Maine, for example. Those two states have the highest proportion of citizens over the age of 65, and that's largely because younger folks are moving out of rural communities for opportunities, economic and otherwise. Secondly, I suspect it's a higher problem in rural communities for older persons because rural communities increasingly rely on nursing facilities to provide long-term care services. So someone mentioned earlier about the Alzheimer's. It's an epidemic, by the way. The Alzheimer's issue, well, those folks in rural communities don't get home and community-based care. They get admitted to nursing facilities pretty routinely. And then last, inside nursing facilities, I hate to say it, but back in the 80s when I staffed one, we used to use the phrase, strap them down and snow them under. We don't strap them down anymore, but we certainly do snow them under. And there's increasing evidence now that opioids have become the new antipsychotic. And what we're finding is just all sorts of examples of what are they called, long-lasting patches of opioids being put on older persons who are demented. It's not good.
Tony, now I want to turn to you because before you came to UGA, you're at University of Kentucky. And as some of you know, Kentucky kind of took the lead, the Attorney General, in suing Purdue Pharma over kind of flooding the market essentially with more OxyContin than what's medically indicated for the population. Is there, once again, is it really worse in rural areas, or does the evidence support that, or is this perception?
Meth was migrating from the West Coast east. And I had a network of primary care clinics, and we were doing cognitive evaluations using the clocks drawing to get the practitioners to see dementia. And we had all these young adults who were drawing these very bizarre clocks. They had all the stigmata of methamphetamines, they had bad teeth. It was very scary. And this was out in Trover. For those of you who know, anybody know Kentucky? Western Kentucky, Trover, the Trover Medical Center. So yes, absolutely, it is a problem in the rural setting, and largely because of what Brian says. It's the aging of the population that provides the medication that people are abusing. But the other part of it is, if you look, there's 2 Sentinel papers that anybody wants a copy of it, I'll send them to you, that has looked at mortality in white America between the ages of 40 and 59. Those people are caring for folks with dementia. That is the group that is disproportionately dying from substance abuse, liver-related diseases. So I think I would suspect that caregiving is underneath this problem in a big way.
Yeah. And Mark, I apologize. I know you guys had slides that you and Mark wanted
you don't have
to
to show my slide. You guys talked about the Medicaid expansion, so that's great.
Right.
I don't have to talk about
that.
that.
No, but they have slides, which we're working on. But just can you address kind of what you found in your research and how it's affecting different population groups?
Sure. I'm going to go back just slightly to middle of last year, just to give the context for CDC's engagement in rural health. So I actually come from a long background of working in rural health in a global setting. And when I transferred over to CDC, I worked for USAID for over a decade overseas, and I came to CDC, and my boss at CSELS, the Center for Surveillance, Epidemiology, and Laboratory Services, said, okay, I have a project for you. Let's update some data on a report that was published in 2014. And so I brought it here with me, and this is really what started the dialogue around rural health, although it's not really about rural health. And this was published in November. And basically what we did with our colleagues at NCHS is we looked at a paper that was published around potentially excess deaths among the 5 leading causes of death in the United States. And what we wanted to do is take those results from 2010 and compare them with mortality data from 2014. And so what we found was a lot of change, a lot of statistically significant change among the 5 leading causes of death. But what was really interesting was that the significant change was a decrease among 3 of the leading causes of death, which was heart disease, cancer, and I'm forgetting the other one, it'll come to me, but there was no significant change in stroke, and there was a significant increase in deaths from unintentional injuries. So Dr. Frieden, after this report came out, he was very interested in this change, and he was, I believe, testifying in Congress, and some Congress members asked about rural areas, rural health, what's happening among the 5 leading causes in rural areas. So we took the same data set, and now we disaggregated it or stratified it by rural and urban counties in the United States. And what we found, then I engaged Dr. Mark Fall and some other SMEs in CDC who are specialists in cancer, heart disease, cardiovascular, unintentional injuries. We found that in rural areas, among the 5 leading causes of death, there was very different trends, and the one that was the starkest, I would say, or the one that was most alarming is the one from unintentional injuries. So what we did in that paper, and that one was just released in January, and because it was so interesting, we have a report that presents the results, and then we had a standalone commentary that was published in the MMWR because there was so much to say about those 5 leading causes of death and about unintentional injury. So I will hand it over to Dr. Mark Fall, who's the SME on opioids, and we have a few slides. If they're not up, I'm sure he can talk to them, and I have the reports here, and we can reference those later if anybody is interested in seeing those. Yeah.
Yeah, thanks, Mark. Just, it's the one at the top. There you go. Thank you.
Hello, it's very good to be here. This summarizes some of the basic epi numbers for opioid poisoning. We thought it would be good to facilitate the discussion for this topic and also talk about the different trends of heroin and something really scary called fentanyl. We don't have anything to disclose. Okay, here's the key chart for this key chart on a national basis. I don't know if we have a pointer. Pointer doesn't seem to be working. Anyway, the purple line represents the most commonly prescribed opioids. Those are the oxycodone, methadone, and you can see it's over the last 4 years from 2011 to 2015, it's been relatively stable. This is as a result of lots of state actions from states, the establishment of prescription drug monitoring programs, CDC guidelines on prescribing, overall awareness of this type of injury. But the problems are really starting to spike up in heroin and other synthetic opioids. And as one gentleman said, the cost of heroin is very cheap compared to the actual prescription drugs that you can get on the street. So we have to sort of be aware if we have an unintended consequence of a policy here, whether if control of these substances are actually contributing to increase of illicit drugs, namely heroin. And the one thing to be worried about is synthetic opioids. They're coming into the market. We've looked at this. We've cooperated with DEA, and we've seen where the prescription for fentanyl has been flat in legal fentanyl. It's actually been through the roof by Drug Enforcement Agency. They've had something like 5,000% increase in fentanyl seizures, and most of it's coming from China with distribution routes through Mexico, cartels. But you can see the green line, we clump it all together. The green line represents any opioid. And the scary thing about that curve is the steep, the slope of it. Why this is dangerous is that the heroin overdose rate is increasing rapidly, and large increases in fentanyl and semi-synthetic opioids. Fentanyl can be 50 times more potent than morphine, and heroin is more potent than general prescription drug medication. The challenges for rural areas, this is a chart out of EMS work. The green represents all the rural areas of the country, whereas the white represents urban areas. 20% of the EMS workforce works in the green areas, whereas 80% of the EMS workforce works in the white areas. So it's very disproportionate, some very big challenges geographic-wise, just distances. Remember, a lot of times when EMS is a key component of all this because they oftentimes are the first part of the healthcare system to arrive when there's a drug overdose. So they're ready with oxygen, naloxone, and standard ventilation procedures. This is the chart that Macarena was talking about. The excess deaths for the 5 different categories, largest categories: heart disease, cancer, unintentional injury, chronic lower respiratory disease, and stroke. The darker brown bars are the higher percentages of what's called excess deaths, and it's all, you can see where the non-metropolitan areas are higher than the metropolitan areas. These are sort of the easier to prevent deaths. drug overdose is the driving this trend for unintentional injury. You can see it's the highest. Unintentional injury typically doesn't get a lot of nationwide coverage, and the exception has been this opioid problem. I wanted to show this out there, show this slide, because there's a lot of different issues in the urban-rural disparity. This chart is a little bit complicated, but the blue line represents burden for opioid with 3 categories, within 3 categories, urban, suburban, and rural. You can actually see the plot for rural is higher, almost, not quite twice as high, but almost twice as high as it is for urban. But the red line represents the odds of naloxone use, the treatment in those different communities. And the left axis, y-axis, and the right y-axis are proportional. So that red line, if there was parity, that red line should roughly be equal to the blue line, and it's not. And there's a lot of reasons why it's not in the rural community. Ambulances aren't always equipped. They're not equipped with the type of staff that can issue Narcan or naloxone. The nature of the distance to actually get to the person, the changing nature of the epidemic. This concludes the slide presentation. I just wanted to whet the audience and give some background on some numbers here.
Thank you, Mark. Information. So I want to bring it back to the panel. So I guess, Tony and Brian, any kind of thoughts on some of that data, and what's driving these discrepancies in these rural communities where we're seeing this much higher fatality rate?
One thing we have to acknowledge is that a lot of medical societies, including the American Geriatric Society, American Psychiatric Association, they all approve of these opioids. They think it's under medically necessary circumstances, perfectly okay to prescribe. So the gray area comes in, when is it misprescribed, or when is it inappropriately prescribed? And I think that's one of the issues we have to address, is a lot of physicians will think that they're doing perfectly legal action, perfectly medically necessary action. And I think in some part that's what's driving.
Yeah. You think there's a concern that too much focus on kind of opioid epidemic might lead to undertreatment of medically necessary conditions like chronic pain and other conditions?
At this point, absolutely not.
So, sorry. 2 quick things is just to follow up on Mark's presentation. We didn't include the slide. It's in one of the papers. But when you look at the mortality trends among the 5 leading causes over a 15-year period, you see cancer and heart disease and the others, decreasing in both rural and urban areas, decreasing at a slower rate in rural areas. But what you see in rural areas in unintentional injuries is this really steep increase toward the latter, I would say, last 5 to 10 years. And from that, we started conducting some other research at CDC, and I'm working with Mark and others from the National Center for Injury Prevention and Control on understanding why that's happening, how it's happening, where it's happening. And we're currently working with Athena Health, and I'll just mention it because Athena Health is one of the largest EHR providers in the country for primary health care providers. And so we have been granted access to their data. We're collaborating with them, and what we're studying now, and it's preliminary, and we have some findings that are very interesting. We're studying opioid prescribing rates among primary healthcare providers in the Athena network nationally, and we're looking at what the different prescribing rates are for rural and urban providers. And what we found, just very preliminary, and we hope to present it at a conference and conduct a larger analysis, is that primary healthcare providers in rural areas are the prescribing rate is 54% higher than in urban settings. So that's alarming. And I think the next step is to understand why. Why is that happening? And I think my colleagues just mentioned a good point about older persons, populations in these rural areas. So.
I had brought some slides today, but I'm not going to show them because our other panel, the CEO panel, did a really good job of talking about expanding Medicaid and what it could mean for access to care. And so one of the things I would like to engage this audience in, because we seem to have a very, I feel like I'm running with the big dogs today. I take a multi-generational approach to this problem because we live in a time where there is a growth of an older adult population. Many families are caring for folks with cognitive impairment. You've got the veterans population that are coming back from combat. You've got growth in Alzheimer's and stroke-related dementia, and that is falling on the middle group that's caring for both them and their children. And in the rural environment, not having the services that you might have in a more urban setting creates problems. And people who are engaged in caregiving, and I never thought I'd be talking about caregiving in the midst of opioid epidemic, but that's what the data suggests to us in gerontology. You have people who, Ann Case, who's written about this, call them deaths of desperation. These are people who are sacrificing their lives willingly to care for family members, but they have truncated their own retirement savings through Social Security. They have cut themselves off from health care, so they can't get the treatment that they need. And by not expanding Medicaid, so we're blocking the caregiver access to things. And so what you're seeing is self-medicating. I think that, so who's our prevention guy? Where is he? All right. So and I applaud your efforts to go into the schools and talk to teachers, but prevention may be achieved, this is what we learned in public health, by working on segments of the problem that don't seem directly related at first. So supporting caregivers may be one of the ways to reduce this problem.
After that, an externality that's happened here at the Senate Committee on Aging, we just held a hearing on grandparents taking care of grandchildren. This was a new topic to me, so I had to do all the background work, and it emerged in the early 90s in relation to the crack epidemic in Los Angeles and other large urban areas, where the caregivers, the middle-aged parents, were becoming addicts and no longer in capacity to take care of their children, so grandparents had to step in. Well, we're seeing a rise of that again in white rural communities where grandparents now are being put into caregiving roles as primary child caregivers because the middle-aged adults are no longer capable or have experienced overdose related to opioids. So this is just another wrinkle in what opioids are doing to the country.
So obviously from all your input and your research, this is a very complex problem, right? It is a medical issue, of course. It's the issue of kind of access, lack of access in underserved rural areas, long distances to get treatment. But what you're also saying that it's a socioeconomic issue, right? Which brings in social determinants of health. Yeah. I mean, to what extent is this kind of a symptom of a broader problem of kind of not investing in these rural communities or seeing what their needs are in terms of maybe more social support for caregiving and other necessary programs?
Well, I mean, and I'm glad you asked that question. One of the models that people are experimenting with is actually paying family caregivers so that they have some income to take care of things. So grandparents, we have that problem here in Athens. Grandparents in the summer who are taking care of kids that they can't afford to even feed. Those policies can have a direct impact on measurably lowering these other problems. When I lived in Kentucky, the great thing about living in Kentucky is I got to see the epidemic 10, 15 years ahead of everybody else. We saw it. We had older adults in eastern Kentucky who sold their prescriptions by the pill to bring in income that they needed. So it is a very complicated issue, some of which can be solved by throwing a little money in people's households. I'm just saying. There's federal legislation. I know the VA initiated a policy of paying family caregivers to care for vets with traumatic brain injury. That policy, I don't know if they're discussing it in the aging committee, but they need to extend that to other families. They've experimented with it in California. It seems to be helping, at least with the caregiving. I don't know that anybody's looked at it yet in relation to the opioid epidemic, but it certainly is worth looking at.
Mark Ryan and Mark, do you have any comments?
Sure. I'll go back to the clinical aspect. Obviously, social determinants are key, and we're studying them more to understand what role they play. As far as the clinical aspect, and I know Mark can talk much more to this than I can, but I want to mention a collaboration that we had with Blue Cross Blue Shield in Massachusetts, which is one of the states that has been hardest hit by the opioid prescription misuse epidemic. And we looked at the Blue Cross claims data for prescription opioids for long-acting and short-acting. And they actually, I believe it was in 2015, developed a plan that was widely consulted in Massachusetts to include government and community stakeholders, pharmacists, et cetera. And they developed a pain management plan. It was a policy shift and a program that changed the way that Blue Cross Blue Shield providers prescribed opioids, and it was a multi-step plan. And so we assessed that program and how it changed prescribing practices and rates within the Blue Cross network there in Massachusetts. And I believe Blue Cross is either the largest or the second largest provider of healthcare, private healthcare in Massachusetts. So it was a really huge sample. And we found that there was a significant decline after the program was introduced. And so it was a successful program. Folks, highlight that program as a model for other states and other private insurers. But a big limitation or criticism of that program, which I think we just talked about, was, well, how is that affecting folks who have chronic illness, and is that affecting their pain management? And we actually controlled for that in our study and looked at oncology patients and found that there was a slight, non-statistically significant decline in prescribing rates among oncology patients. So I would say the data supports the idea that pain management programs are a positive thing. They don't necessarily affect those who need opioids the most.
Anything on the clinical side?
Yeah, I think we have to recognize that the stark difference in rural communities versus urban communities. The whole EMS structure is so different in rural communities. The time that it takes to get to person to treat, the absence of medically assisted treatment centers, they virtually don't exist in rural areas. There's been some advances that do affect rural areas, such as Florida's shut down pill mill laws. Texas has done the same. Some other states have been really active in that area. The advancement of prescription drug monitoring programs that basically record every prescription in a state, and a physician is either mandated or not mandated, depending on the state, to look up the actual patient's record before they make a prescription. We worked with electronic health records, integrating the actual amount of pills, the milligram morphine equivalent, into those records. There's things that we can do, but we still have to remember distance is the big issue.
Brian.
Just to add to that, back in the 80s, anybody had grandparents or parents in nursing facilities, it was pretty bad, the amount of antipsychotics that they were on. And it was so bad that it took an act of Congress to stop it. It's called the Nursing Home Reform Act. It was passed in 1987, and it effectively stopped the overprescribing of medications. And one way they did that is they let the states set up these oversight systems. In Iowa, for example, they're called Inspections and Appeals Department. This is a nice compliment to our previous panel. I like those things. They go in and they inspect prescribing patterns, and they reconcile the prescribing practice with the actual clinical indications. And if they see something amiss, they'll issue some sort of penalty. Well, over the years, two problems have occurred. One is the class of drugs that opioids now have occupied. They're not regulated under the Nursing Home Reform Act, so they go unwatched, if you will. Second thing, some states have deliberately chosen to underfund these inspection systems. So you'll find in a state with a large rural population, maybe one person is assigned to do all the investigations. And if that person does find anything, we've done research on this, and reports up to their supervisor, that information is usually tabled. If that information gets beyond the supervisor to the point of issuing some sort of penalty, that penalty gets litigated and settled and put away. And even if that happens, where a fine is issued, these folks are organized well enough to put a lien on the executive branch in the governor's office and say, hey, you know, we gave your campaign last year, we're getting fined for doing these inappropriate prescribing practices. Help us out here. And usually what you'll see is an executive decision to reduce the fine, if not get it taken away altogether. That to me is a big problem.
Yes, so I'm glad that you and Mark kind of turned discussion to kind of regulation. It seems like there's a lot of regulatory failure going on that's contributing to this opioid problem. And so one of the solutions obviously is monitoring prescribers, right? Physicians prescribing opioids. But to what extent are the manufacturers or the FDA kind of more upstream regulation? Is there more need to look at, well, where are all these drugs coming from? Obviously, there's illicit markets and legal markets, but could there more be done to kind of stem the flow of kind of overprescribing these legal drugs outside of monitoring physicians?
Feel free.
No, I was asking to help everyone.
Okay,
Go ahead.
It's rare that a person will admit in public that they don't know anything. I don't know anything about that question that he just asked, but I would like to make a comment in a completely different
Go for it,
venue.
Tony.
I didn't want to leave you with the idea. Brian paints a very bleak picture of long-term care based on the 80s and 90s, and it was really grim. Fast forward to the now in Georgia, there is a fund of money called the Civil Monetary Penalties Fund. And it is fines paid by long-term care facilities for bad behavior. But those funds are available to go in and do projects that improve care. I am, full disclosure, the recipient of one of those funds. And part of the problem we're addressing is the larger framework is empathy. We're listening and teaching staff, their families, residents, and the larger community about the issues that are driving people literally to drink and drug in dealing with folks who have advanced dementia. Georgia has recently opened up that fund. We're doing training across every facility in this state. It's called the Virtual Dementia Tour. If it comes to your neighborhood, by all means, go in and learn about it. You'll learn what it's like to walk in the shoes of someone who has dementia. It will help your understanding tremendously. So it is now illegal, really, to tie people down, and it is illegal to drug them. And one of the outcomes we're looking at in the Virtual Dementia Tour is use of antipsychotics. So there's hope on the horizon. I don't want you to be, sort of, things can get better, and they are.
Thanks.
To add to that, actually, CMS, Center for Medicare and Medicaid Services, started a program called Dementia Training Initiative, and it's been hugely successful. They've gone out, just like Tony mentioned, and they're providing education to prescribers in nursing facilities and other types of long-term care facilities. And we've watched over the last decade the antipsychotic prescribing persons with dementia has gone down substantially, especially in the states that were high to begin with. But it hasn't been pervasive, and remember, it's only a voluntary participation. So We do need a stick involved here as well as a carrot.
Yeah. So go ahead, Mark.
I'm sorry, but the FDA question, remember?
I do.
I've been working with the FDA on naloxone formulation, and what we're finding is it takes basically the multiple naloxone administrations per patient has increased 25% in the last 4 years, which is really rapid. That means the first dosage isn't working, they have to give the second dosage. And at times it goes up to 10 times. So we're working with FDA. We have an important paper coming out next week showing that this is happening on a national level, and it's mostly because of fentanyl. The danger, as the higher potency of the opioid, the more reversal is needed. So FDA is a key partner in that, and they assembled a group of people, and the advisory committee all voted last year to increase the dosage in naloxone. So that's one thing.
Yeah, so that's an important harm reduction strategy, right? Kind of addressing some lethality of the opioids out there. And I guess related to that, yesterday was April 20th. Yeah, I remember 420. And so this is a segue. Some people are getting it, yeah. Harm reduction, April 20th. I'll let you guys figure it out. And this came up in the last discussion with the Jim, and I think Russell Edwards asked the question. And Jim referred to David Bradford's research here at UGA on looking at states where medicinal marijuana was legalized. We saw a reduction. I think he was looking at Medicare data and prescription of opioids. To what extent can expansion of access to medicinal marijuana be an effective harm reduction strategy, or is it simply replacing one addiction with another? What are your thoughts? Brian, go ahead, because I know you publish in this area.
Well, I'm not licensed to practice medicine. Let's put that out there first. I got involved with this issue because the state of Iowa asked me to provide some counsel. They're trying to move forward with the medical cannabis program. So by way of history, I didn't really have a lot of expertise in this area. I did have the expertise in the opioid prescribing and the problems going on there. And as we went through our legislative process and we brought forth hearing participants, we had a very compelling testimony from a woman who had a baby with epileptic seizures. And that was the winner, because during the testimony, the baby was seizing, and she basically told everybody, when the baby gets a tincture, liquid substance of cannabis, this all goes away. And I thought that was enough to move our legislators forward, but that was for me the flashpoint about, well, what about all these older people in nursing homes? And another thing we're not talking about is actually the undertreatment of pain at the end of life. Hospital administrators and physicians, ironically, will step away from prescribing opioids when a person's basically in their last 12 months because they're fearful, risk averse. It didn't add up. So we started scratching around and looking for information on this, and we went into about 8 different states, held focus groups, talked to the program directors, and we found 3 key things. One, every state program director said, we have more older adults on our rolls than we ever expected. Higher proportion of older cannabis users in our state medical cannabis programs than we even counted on. Colorado, Arizona, Montana, the numbers were all huge. Secondly, when we did the focus groups, it wasn't just, and this is what NIDA kind of throws out there, they look at this as a substance abuse or misuse. They weren't looking at it from the flip side, the alternative, of maybe this is okay. And when our focus groups, it wasn't all the hippies, the Beatles loving, generation coming back to it. We found a significant number of people who never used it, always had a negative attribution towards it, were afraid of it for legal reasons, but they were at the end of their line. One person in particular had MS, really struck me. MS is debilitating in the sense that after a while you can't even speak. And he said that was a point he reached, and he got some patient education literature from his MS society, and they said, try it. And he did, and there he was talking to me. And he goes, I don't know how it works. I don't know the FDA rulings on this, but I'm doing it. And he used to throw guys in the brig. He was a military guy for using drugs. That was such a huge conversion moment. And then the last thing is a lot of people, quit putting it into the narcotic space. If you talk to botanists, if you talk to chemists, it's not a class 1 narcotic. It's more like coffee in its genetic makeup than it is opium. So I think this is a huge opportunity, but we can't do studies right now because nursing facilities are federal, and federal oversight precludes us from doing studies in nursing facilities on cannabis.
Tony, other panelists, anything to add? With the time we have left, I'm sure there's questions from the audience, so I want to see what you guys think. Yes. No, thank you for that comment. It's very. No, thank you for bringing that historical perspective and the personal stories. Any other questions for the panelists? Yeah, Russell.
What sort of movement do y'all see towards rescheduling marijuana to promote these studies? Like move something?
Under the current administration? At the federal level, I don't see any movement. Now, this is a great, as a policy guy, this is a great study in federalism. We're in a law school, we can say that. I mean, here we have we want states to stake out innovation, so they should not get in the way of this. And I think that's perfectly okay, because right now, the states are learning from each other. I talked to Minnesota. They got a really well-organized program, so they're getting to be known, and other states will call them. So it's kind of this proliferation effect that I see going on, despite what's happening at the federal level. I think the key at the Fed level is how much money are they going to invest in actually trying to implement their current policy. Hopefully, they kind of get diverted with other things.
To follow up on that, we got any medical education people here in the room left? Anybody from Augusta still here? Part of the problem, part of what you're alluding to, is how we teach people to prescribe. Right now, we don't allow physicians to prescribe non-pharmacologic interventions for anything. No relaxation techniques, no, let's manage you and see you frequently to engage in weight reduction. I mean, opioids are just the tip of the iceberg. So part of it is a medical education issue. I used to teach residents and medical students, and still do on occasion. That is a problem.
Just to add to that, I'm not an advocate for cannabis. It's just it's one alternative. There are lots of other things we could be doing to address pain in my population of older adults: physical therapy, nutrition. Social isolation is now being identified as a big contributor to poor health outcomes. But again, to be dark here, it's money. That's staff that has to come in and do the cognitive behavioral therapy. That's money we have to pay for better food. That's money we have to spend on having a social contact group with seniors. And any finance guy will tell you it's a lot cheaper just to write some scripts.
On the number of pills, in 2016, the CDC came out with a prescribing guideline that I think it's the #1 downloaded guideline at CDC, and CDC it hasn't been a smooth process. Not everyone in the medical community agrees with the restriction on pills. It's actually MMEs, milligram morphine equivalency, but it equates to the number of pills, and it's a move in the direction I think you've raised, and it's a start.
I see we're out of time for the panel, so please join me in thanking the panel for a really important discussion.